Hopefully everybody can see my screen. Right, so thank you so much for asking me to talk about emerging concerns in aging thalassemics. And I think these concerns are really things that are causing anxiety for a lot of patients, because as people are getting older, they're noticing more problems developing with their health. So if we look at the age of thalassemia patients, what we can see is that there is an increasing population of older patients and a decreasing population of new births. So as time goes on, we will end up with a large population of people in their 50s and 60s and very few patients left in the pediatric setting. And certainly my experience at the Whittington is that, you know, we've now got about 15 children with thalassemia, that's below the age of 15. The rest of our population, a large majority of that population, is over the age of 40. And the reason we're here is that, you know, we know that good iron chelation has had a really positive impact on survival. And Bernadette Modell's paper, so the complications we've now got to deal with in the older thalassemia population are basically cardiovascular problems, gastrointestinal problems, and endocrine, renal, and musculoskeletal. And I would say that the complications that most affect the patient's quality of life are actually the musculoskeletal problems in a large part. So what do we know about cardiac iron loading? Well, we know that the iron burden for patients over time has reduced considerably. So this is data from the Whittington Hospital, where we looked at all patients with cardiac iron loading over a decade. And what you can see is that the total absolute number of people with cardiac iron loading, that is T2 stars that are in the high risk categories, has reduced. And that's because we know that if we have a patient with cardiac iron loading, we give them intensive iron chelation, we can reverse that cardiac iron loading. The problem with that reversal is that, you know, patients get better, but we didn't know, and we are now obviously learning over the last 5 years or so, that patients do get long-term late sequelae of cardiac iron overload. So even when they have no iron left in the heart, they can still get cardiac complications because of what had happened previously to the heart when there was iron in the heart. So cardiac iron loading has improved because we've got better availability of iron chelation. We're more effective at using iron chelation to help treat myocardial iron loading. And we work much better with our patients on improving compliance. So what we now know about management of cardiac iron overload is that all the drugs are effective. It's all about compliance, making sure the patient is getting the right dose, they're taking it correctly. And with all of the drugs, we will see improvement in the myocardial iron overload. And this is all data, obviously, from the Whittington Hospital cohort, where we've had MRI assessments for our patients since the late 1990s. So the late sequelae of iron overload, even if you've got no iron in the heart today, we know that about 40% of our patients over the age of 40 are likely to develop cardiac arrhythmias if they have had iron in the heart previously. Atrial fibrillation is the commonest cardiac arrhythmia, but patients can get other tachyarrhythmias. So that's heart rhythm abnormalities that make the heart go faster. And the reason for that is, we think, the scarring that has happened to the heart muscle when there was too much iron in the heart, when the patient was much, much younger. So even if the first MRI scan was normal, so say, for example, you've scanned your patient for the first time in their life when they were 30, it does not reflect the risk of late cardiac arrhythmias, because they could have had severe cardiac iron loading when they were 15 or 16, and MRI scans may not have been available at that time, and you therefore don't know how severe the cardiac iron loading was. So if a patient is presenting with a tachyarrhythmia at a young age, so in their 40s, and that is young for normal people, we would not expect normal healthy people to get atrial fibrillation in their 40s. So if you have a thal major presenting with those kind of problems, it's really important that that is investigated seriously, managed by a cardiologist who understands that this may be something that is as a consequence of the previous cardiac iron overload, which may be documented or not documented. The other thing I think that's important to remember is that as patients get older, they are the same as other people. So they are likely to get cardiac problems the same as normal people. So heart attacks, angina, other problems will develop. We've had, some of our patients have had heart attacks from atheroma. Some of our patients have got high blood pressure. Some of our patients have got angina. And it's important to remember that all cardiac complications are not necessarily related to iron overload, past or current, and they may be related to just your patient being a normal patient or you being a normal person. The other problem that we have with our patient population is the prothrombotic state and the vascular complications that thalassemia patients get because of that. And there is an increased risk of thrombosis in thalassemia patients, particularly patients who've previously had indwelling lines. So if they've had an indwelling PICC line, portocath, Hickman line, we're seeing an increased risk of thrombosis, predominantly in the chest where the line was inserted. And some of our patients have got superior vena cava obstruction from the lines having been placed in over the previous years. We've also got an increased thrombotic risk in our splenectomized thal patients, and a number of our patients have actually got significant and serious complications as a consequence of this, particularly pulmonary hypertension. So in our patients, we've got a lot of problems with superior vena cava obstruction. It can cause really severe and debilitating symptoms, swelling of the face, puffing up of the face, feeling of congestion. And when they don't take the anticoagulation, they get really symptomatic, but when they are anticoagulated, the symptoms do tend to resolve. So our strategy for reducing the risk of these kind of complications has been that we anticoagulate all patients with indwelling lines, and we give them therapeutic anticoagulation. So that means warfarin with a target INR of between 2 to 3, or any of the newer drugs like rivaroxaban and doxaban. All of the new drugs are absolutely fine for this. Since then, we've seen less line-related thrombosis, but patients can still develop thrombosis. And one of my patients with a good anticoagulation level got a clot in the right atrium whilst they had a line in place. So it's really important to make sure that if patients are developing thrombotic complications, that people are taking these seriously. People can get stroke as a consequence of the cardiac problems and the thrombotic problems, and we are recommending that all patients who have atrial fibrillation, and that is either as a consequence of previous damage to the heart from iron overload, or they've got atrial fibrillation just because of age, they should be anticoagulated the same as any patient with atrial fibrillation. So a lot of our patients are now being anticoagulated for atrial fibrillation. Pulmonary hypertension, 2 of our thal majors have pulmonary hypertension, and 2 of our thalassemia intermediate patients have got pulmonary hypertension, and all of these patients are post-splenectomy. So one of our patients has 2 of our patients were very successfully managed with pulmonary thromboembolectomies, which are really complicated procedures. And I think it's really important to advocate for this to happen. There is nothing to stop a thal major patient from having the procedure. You just have to prepare properly in advance and do it with a clinician who is an expert in doing this. And our endarterectomies have been very successful actually for our patients. So I would definitely say that anything that can be done to help ease the burden of pulmonary hypertension should be done. The other thing that I would very strongly advocate for is that if someone does have really bad pulmonary hypertension, but otherwise they are in good health, there is no reason why they should not be a candidate for a heart-lung transplant. And again, I would strongly advocate for that, particularly in our younger patients. So if someone's below the age of 50 or they're 55 and they meet all of the criteria for a heart-lung transplant, then we should definitely be advocating for and supporting that to happen. So the prevalence of these complications are increasing as people get older, and I think that that's another really important thing to bear in mind. We have a lot of problems developing with the patients as they're getting older with fatty liver disease. We have to remember that, you know, at the end of the day, a diagnosis of thalassemia is simply a diagnosis of thalassemia, and our thalassemia patients are human beings and they have lifestyle issues the same as everybody else, and they will get diseases like fatty liver disease, type 2 diabetes, the same as everybody else. The other problems that we are seeing a lot of are chelation-related side effects, particularly gastrointestinal ulceration and GI bleeding. As people get older, it's not necessarily a complication specifically related to age, but I would say that this is a complication that is handled with more challenges as a patient gets older, because they've got so many other complications to deal with. Having the additional burden of gastrointestinal ulceration or bleeding makes the situation much worse. And the same applies for diarrhea. Too much iron can damage the pancreas, and one of the things that we are seeing a lot of now in our patients is pancreatic exocrine insufficiency in patients who are presenting with unexplained weight loss and diarrhea. And that is when we do the fecal elastase test, it's low, and our patients then end up needing creon enzymes to help support this side of their treatment. I have to say, in the last 5 years, probably the majority of our patients who are over the age of 50 have now got pancreatic exocrine insufficiency. And we are getting an increasing number of our patients who are in their late 40s developing this complication as well. And it is difficult and challenging for the patients who've got this. Excess iron can cause liver cirrhosis and an increased risk of liver cancer. And we mustn't forget that even though we are worried about hepatitis C and the risk of liver cancer, we need to remember that our patients should still be screened because of iron damage, not related to hepatitis C, but specifically related to iron overload. And we should still be vigilant for hepatocellular carcinoma in our patients who are and have never been infected with hepatitis C. And of course, there are other hepatitis infections that can cause liver cirrhosis, often many decades after the exposure. We can see that there is an increasing number of deaths from heart disease and from liver problems, but in particular, liver problems are increasing, whereas the heart disease, which tends to be the problem in younger patients, is reducing in amount. And the liver disease is now, I think, my primary concern for a lot of my thalassemia patients going forwards. So hepatocellular carcinoma, the incidence is about 3% in hereditary hemochromatosis. In registry data that we know from the Italian registry, 36 patients with hepatocellular carcinoma were with a diagnosis of beta thalassemia intermediate, and that is actually related to iron overload rather than hepatitis C. And I think that, you know, chronic iron overload, high levels of iron overload, is something that we really need to be vigilant about from a long-term risk for hepatocellular carcinoma. So what we're recommending nowadays is that any patient who has ever had a liver biopsy with evidence of cirrhosis or fibrosis should be on regular surveillance for hepatocellular carcinoma. So regardless of whether it's hepatitis C related or not, they need to be on surveillance if they've ever had cirrhosis or fibrosis on a biopsy. And they should have endoscopies annually, along with 6 monthly ultrasound scans. And any patient with severe iron overload at any time in the past should have investigations done. to look for fibrosis or cirrhosis. So what we are doing now is that we are proactively at the Whittington doing fibroscans on all of our patients as a baseline. If they have significant fibrosis or cirrhosis, we are then putting them onto regular surveillance. And that is regardless of a diagnosis of hepatitis C or not. We're seeing a lot of endocrine complications in our older thalassemia patients, and these are often developing at low levels of iron burden. And again, I think it's because of damage to the endocrine glands that happened many, many years ago, and it's now manifesting. And what we can say is that we know that hypogonadism is very common in the younger patients, but we are beginning to see diabetes becoming more of a problem as patients get older. And this is data from the Whittington. And what you can see here is, there's a large number of patients with multiple endocrinopathies, and over half of our patients actually have diabetes or abnormal glucose tolerance tests. And this is actually linked to, we found a relationship between cardiac iron overload and patients developing diabetes or impaired glucose tolerance tests. And so what we have is about 40% of our patients are diabetic, 20% are abnormal glucose tolerance, which is a lot of patients from a complication point of view. The other thing that in the Mediterranean cohort, but also in the Whittington cohort, we are seeing more of is impaired growth hormone function in the older patients, not at the point where they need growth hormone therapy, but certainly low enough to cause ongoing problems with persistent fatigue and low mood. So growth hormone deficiency is something that we are now looking for. Growth hormone treatment can be started on patients, but that is done with the support of our endocrine colleagues to do that. And of course, we know that iron chelation drugs are nephrotoxic. We know that diabetes and other problems develop in patients. All of these things will impact on the kidneys. And one of the things that we are seeing in patients is a decline in renal function over time as people get older. A lot of our patients are developing problems with kidney stones. Many of them have got kidney stones which come and go and cause really quite considerable problems in the patients who have significant problems with kidney stones. And this is data from a review by a team looking at renal problems in the diabetes patients. And what you can see is that in most adults who were treated with Desferal, the eGFR remains normal, but they do have leaky kidneys, basically, with leakage of uric acid, phosphate, and other things. And it's kind of a predisposition that leads them to develop renal failure as time goes by. So we could use these tests as a kind of screening test, a bit like we use microalbuminuria in diabetes as a screening test to predict which patients are likely to develop problems. So I think from a point of view of where we are with the thalassemia patients, the key thing I do want to highlight is that patients will have long-term sequelae from iron overload that happened many, many years ago. But we also have to remember that the patients are normal people and they will get normal problems. And mobility is a big issue in a lot of patients as they get older. And this is driven by the osteoporosis and by the degenerative bone disease that a lot of patients are getting. So osteoporosis is a problem. I think it's been discussed very widely over many years. We don't have the best treatments available. And quite often all we're doing is just supporting care with bisphosphonates and advising patients on lifestyle factors such as reducing smoking, taking regular exercise to help support them. But the big problem that I'm seeing as my patients are getting older is degenerative spinal changes. And this is a review of all of our patients who'd had problems with pain and had had imaging done. And this is a little bit old. We've had many more patients have this done. Now, this is a 46-year-old patient, and this is her spinal scan. And what you can see here is considerable bulging of her discs, which is causing quite a lot of problem. And this problem starts early. This is a 30-year-old patient with evidence of crush fractures and disc protrusion in the lumbar spine in a 30-year-old. And I'm in a really difficult position because I'm telling all of my patients that the only thing you can do to protect yourself is to start looking after your back early, and that means regular exercise. And I'm strongly recommending that everyone does yoga and Pilates to help strengthen their muscles, because a lot of the problems with the degenerative changes are things that we cannot reverse, we cannot do anything about, and patients will just have to learn how to adjust their lifestyle to help them manage those problems that they are developing. So I want to thank everybody very much for listening. I'm really happy to answer any questions if you've got any questions. And I will stop sharing.
Thank you very much, George. Yeah. Unmute, please, yourself. Thank you so much, Dr. Shah. Yes. This is really a very important topic for thalassemia patients.
Thank you. Yes, indeed. It is a very important thing because, as you said, in England, and I'm sure in many other countries, thalassemics don't die young, and therefore we need to start knowing what is coming our way, and to see whether there is anything that we can do to help ourselves and help you guys trying to treat us in a better way. Is there any questions from anybody, please?
I think Dr. Michael.
Sorry, I haven't got a question. I just wanted to make a remark. Farrukh, your presentation was pretty comprehensive. There was one issue missing. Perhaps it's not part of your experience, but it's certainly something that we're seeing here, and that is retinopathy. As patients are getting older, especially the ones that were taking Desferal for many years, are actually getting retinopathy, which is sometimes irreversible. I just wanted to add that to our worries and woes.
Yeah, I mean, we've not seen, thankfully, significant retinopathy in the UK population. So, which is good. I think, but I think there are definitely patients around that have had significant damage. So we should be definitely monitoring for those problems.
Thank you.
Any other questions? I have one, if you don't mind, Dr. Shah. It seems that there is a little bit confusion into the level of ferritin at the moment. We are aware that it should be nothing more than 1,000, 1,500. But at the moment, from what we are reading, is that people are now recommending that ferritin shouldn't be higher than 500 or even less. Is that something that you...
No, so I think I have to say that I appreciate that there are challenges with the ferritin, but I actively tell all my patients, do not chase your ferritin. The MRIs give you the most accurate measure of your iron level. If your MRI is good, so I would say a liver iron of below 5, my target is 3 for my patients. I'm a lot stricter. If your liver iron is good and generally below 5 milligrams per gram dry weight on a ferri scan, that means your liver iron is good. And regardless of if your ferritin is 3,000 or 500, your ferritin is reflecting something different. It's reflecting iron, but it isn't necessarily fully reflecting iron. It may be reflecting fatty liver disease. It may be reflecting inflammation or something else. And it's really important to not chase the ferritin, but actually really focus on what the liver iron is, because that is actually telling you what the storage iron is for you as an individual. There's a risk, a very serious risk of overchelating people who've got ferritins of 5,000 or 6,000, but liver irons of 2 or 3, because then they'll develop retinopathy, they'll develop all of the other complications. And likewise, in a lot of people on deferiprone who may have ferritins below 1,000, there's a very real risk of underchelating them because their liver iron may actually be 15. So the MRI is the most important guide for what to do and when to worry about your iron burden. And the ferritin is useful for individual patients as a trend, i.e. is it going up or is it coming down? But it certainly shouldn't be used as your bottom line for, everyone needs a ferritin of below 500, because that's not a realistic target.
And of course, Dr. Shah, you're bringing us to a very important issue here that we are concerned active. The greatest majority of our patient population does actually not have an access to a standardized MRI methodology for iron load monitoring. And it is our great wish, and we are focusing considerable efforts in the last year, and we will do so this year, because the greatest majority, more than 95%, actually very few centers like the center, your center, UCH center, or a couple of centers in Italy, perhaps in Greece, I'm not sure, but there are very few centers that are actually using FerriScan or FerriSmart, and they are using a software on the MRI that is actually calibrated or standardized. Therefore, this is what we are worried about, because you consultants, international experts that are involved in writing the guidelines for Thalassaemia International Federation and are giving this important information to our patients, actually our patients do not have access to correct iron assessment. And we will need your help in putting out a position paper and a declaration to actually make an effort to force, if possible, that this should go accompanied with the chelation. You cannot pay for chelation without correct assessment of iron load. This is not just for the patient first and above all, but also for the healthcare system and for all the resources that are being spent on chelation. So thank you very much for this.
One more question.
We need to move, please. We need to move.
It's very, very important. Sorry, just for a second. All the patients that are watching us right now are mostly European. And we have a tremendous problem in Europe about what hemoglobin people should be transfused at. If you speak to any of our colleagues in Germany, in Sweden, in France, they are transfused at something like 7, 8. Is that correct?
Well,
it's changing.
Guidelines are very clear on that, George, and I think that both patients, families, and treating doctors, it's high time that they should adhere to some kind of guidelines. So,
totally. The BSH guidelines are really clear, transfusion at 95. And it's as simple as that.